Hello, my name is Scott Urquhart. I'm here at Meds East in Orlando. This is our 8th year and 16th meeting. I practice endocrinology at Fredericksburg, Virginia.
My name is Kathryn Kreider. I'm an assistant professor at Duke University School of Nursing and a nurse practitioner in adult endocrinology at Duke University Medical Center.
Michael Clark, and I practice general and preventive cardiology at the Heart Center of North Texas in Weatherford, Texas, and I hold a clinical adjunct appointment as associate professor at Torrey University.
Well, I've been actually had an opportunity to watch the lecture that was brought in by our guest speakers, who we do appreciate coming into, kind of an extension of the faculty that we have here at Meds, and very impressed by the lecture, and it was a wonderful addition to provide extra information that surrounded some of the lectures that were previously covered on diabetes management, diabetes medications, and then some of the cardiovascular outcome benefits we're seeing from some of our newer classes of diabetes medications, the GLP-1 receptor agonists and the SGLT2 inhibitors. So first of all, I'd like to just ask Michael a question. He covered information regarding the plumbing and the electricity and the structural. So we're looking at, cardiovascular disease, so the complications with the vasculature, and then the myocardium with heart failure, structure-wise, and then also some arrhythmia information. So just kind of talk to us about, what you're doing and where you're seeing these agents fit in to your practice. Now we have diabetes agents being put into the cardiology practice.
Well, that's an important part of understanding this disease process, because as we know that over the years that optimizing glucose levels doesn't seem to help improve cardiovascular outcomes, though certainly addressing the risk factors all associated with that tends to help with that. And so, whenever we have medications which help improve outcomes, and especially in this regards with heart failure, because we see still an increasing number of patients who get a heart failure. And I used to tell my primary care colleagues, you're doing such a good job helping people live longer, they have more opportunities to get heart failure. But certainly diabetes can encourage changes in the cardiac or in the heart functionality, and as a consequence, increased chances for heart failure presentation.
Yeah, it's a great point. You made some other points, and we've heard this in some of the data, that patients are actually developing some of this early heart failure that they're unaware of. They're walking up and down the stairs, and they're actually developing heart failure without truly having what we would think of as coronary disease.
Yes.
And these newer medications are kind of echoing around the benefits. And Kathryn, I want to just talk to you as we just kind of build on to that. We talk about these cardiovascular outcome trials that began in 2008, and they were originally intended to look at non-inferiority and safety, but we stumbled across some superiority findings and some benefits in these classes. So you spoke on all of them, and we gave a nice overlap, but you spoke primarily on the two that have FDA labeling changes, the leader and the MPAS. So kind of just explain how that's fit in with your endocrinology, and now we're talking with cardiology, so it's kind of this joint discussion. So kind of elaborate a little bit on that if you can.
Sure. When we look at patients with diabetes, my primary concern as a clinician is their risk for cardiovascular disease. And so we have always historically looked at reducing their risks in these areas: blood pressure, lipids, antiplatelet agents, etc. And now we have diabetes medications that have also been shown to reduce their cardiovascular risk, which is an incredible, addition to our toolbox that we have as clinicians. So I used those medicines before they had the FDA labeling, but now I feel even more confident in prescribing these agents when possible to patients, because I feel that the data very clearly shows a benefit to them from that perspective. So it's been a great addition to my practice, and I would encourage anyone to use the agents. And now we're starting to look at whether or not this is a class effect, because more trials are coming out showing similar effects for these agents. And that would be even better because there's more options for patients. So that's how it's fit into my practice thus far.
Yeah, and I think one thing we have to always be mindful when we present data and case presentations as such, we need to make sure that people understand that these labeling changes are made in patients with diabetes with, they already have pre-existing cardiovascular disease, so we don't extrapolate that information that it means that all patients are going to have a decreased risk in events.
Right.
But I think the one thing, and we all see this in practice, and we try to do risk reduction for improvement of quality of life, and some of the things that I think we really pay attention to is what more could we be doing thinking early in the game versus too late when they come to see you. So I think that the interesting part would be is how we're going to collaborate together with cardiology, endocrinology, and also within internal medicine, family practice though. Any additional points that you'd like to add that maybe you saw within your trial that you think would be important for any of the viewers?
Well, I think Dr. Kreider brought something up very important, and that's understanding changes that may indicate underlying coronary disease as well as cardiomyopathy. Diastolic heart failure, diastolic dysfunction is very often missed. And just as you mentioned, changes in functionality. I walk up 3 flights of stairs, it used to be okay, now I get short of breath. Or that patient with microalbuminuria, that can be one of the earliest indicators of cardiomyopathic changes, and that could be a clue. I need to get these people in and get them screened, as well as, that's, to me, in my world, in cardiovascular medicine, that's an indicator that these newer agents may be beneficial at protecting these patients. And almost with any medical advances or with any medication, the earlier you institute something, the greater the chance of providing the benefit for the patient.
Yeah, thank you. Anything else for you?
I just want to add, I think it's really important for us as clinicians to stay on top of this as the data and the trials are being released. This has really huge implications for our patients. And so I know we all get busy and it's hard to keep up with some of the trial data that comes out, but this particular issue is really immense for our patients as far as cardiovascular risk reduction. So I think keeping an eye on your emails and the press releases and the smart briefs and all those things that we get is a really critical part of being the best providers that we can be.
Yeah, excellent. I thank you both for joining us here at MEDS. It's always a great opportunity to share and build upon with other colleagues and the additions that you brought as our guest faculty. So thank you for joining us here.
Thank you.
Thank you.